Hi all, welcome back to the emergency medicine lecture series. In the previous video, we have discussed about general management of a poison patient, which included identification of the poison patient and resuscitation of a poison patient, including decontamination. Now let us proceed into toxicology a little bit. Let us start with rodenticide poisoning in the current lecture. It is going to be a case-based lecture presentation. I am Dr. S. Prakash Babu, Associate Professor of Department of Emergency Medicine at KIMS and RC Changalpattu. By the end of this lecture, you should be able to understand the basic principles of rodenticide poisoning, including the mechanism of action and the classification of commonly used rodenticides. You should be able to identify a case of rodenticide poisoning based on telltale signs and the clinical features. You should be able to administer first aid therapy and obtain required consultations. Devise a plan for management of the case during the patient's stay in the ED and predict the prognosis and convey the same to the patient attendants in an appropriate manner. Because rodenticide poison, most of the rodenticide poisons, death is inevitable, whatever you do. So let's proceed with the case. So case 1, there is a 5-year-old child presented to ED after accidentally consuming cereals kept as a rat bait. On presentation, the patient had gum bleed and there were mild petechia over the body. Her PT and INR have been tested, which seem to be elevated. Other liver and blood parameters were normal. The question here is, what is the probable diagnosis in this patient? What is the probable compound that the patient has ingested? And how are you going to manage? These are the questions we intend to answer by the end of this lecture. Let's proceed with the next case. Here you have a 21-year-old female who has consumed a dark grey crystalline powder present at home along with water. Initially, she had vomiting and there was upper abdominal pain. Was treated at a local hospital for gastritis initially. The patient has presented to ED on day 3. When the patient has presented to the ED, there is a history of generalized weakness, yellowish discoloration of the urine, and there was jaundice. She also had a right hypochondriac pain, which was severe, and she developed oliguria and was started on dialysis. Despite all the efforts, she eventually succumbed and died. Look, what is the compound that she had consumed? What are the clinical features and the management options available to you? And how do you predict prognosis in this case? And how do you convey it to the attendants? So let's start with classification of the compounds. As we proceed in the lecture, we will know the answers for the questions what we have raised in the case scenarios. There are mainly 2 classes of compounds which can be used as rodenticides, which can harm humans when humans are consumed. The first and foremost is, most of the compounds nowadays in use include anticoagulants, including warfarin, superwarfarins like hydroxycoumarins, brdyfacom, difenacom, coumaril, and bromadarin. Non-anticoagulants can be further divided into metals, including arsenic, barium, yellow phosphorus, zinc, aluminium, and thallium. Fluoroacetic acid and its derivatives. Thioureas, which includes alpha-naphthalthiourea, bromethylene, norbromide, and plant derivatives such as strychnine. So first let us concentrate on the aluminium and zinc, which are usually used as phosphides for rat baits. Zinc phosphide is a dark grey crystalline compound which you can see in the picture. This is zinc phosphide, which is dark green crystalline powder, and it is usually mixed with cereals and kept as a rat bait. And aluminum phosphide, which usually comes as a rattle paste or as tablet form, which can be again mixed with either water or the rat oil paste can be directly placed at the sites where rats frequent as bait for them. They attract the rats and they kill the rats. Modes of exposure to this aluminum and zinc phosphide is usually suicidal, where an adult patient intentionally consumes the poison knowing that it is a poison. Some accidental cases have been reported in children, but homicidal is rare because they have strong odor and they can be easily identified. And they have a garlicky odor which differentiates them from other compounds. The garlic odor comes from the phosphorus compound. Coming to the mechanism of action, as such, aluminum phosphide and zinc phosphide are not poisonous. When they enter the GIT, they combine with water and phosphine gas is released. This phosphine gas is the one which is the culprit for all the clinical manifestations. Once the phosphine gas is released, it spreads throughout the body and there is extensive cellular necrosis, especially in areas where the cells are actually dividing. Suppose in the liver, it causes centrilobular necrosis, leading to permanent hepatic failure, and the permanent hepatic failure leads to bleeding dialysis. In the kidneys, it causes acute tubular necrosis, toxic acute tubular necrosis, and there can be acute renal failure with severe metabolic acidosis. Endothelium of the arteries and the veins, there is necrosis and there is dysfunction, which leads to profound vasodilatation, hypotension, clotting abnormalities. Finally, it ends up with disseminated intravascular coagulation. And then in the heart, it leads to endothelial and myocardial necrosis. There is global cardiac depression, and profound hypotension, and patient goes into refractory shock. Coming to the clinical features, they can be divided into three phases. Phase 1 is the gastrointestinal phase. Phase 2 is the quiescent phase where you don't see any symptoms, and phase 3 is the systemic phase. Phase 1 occurs usually immediately after consumption because of the strong pungent garlicky odor and usually lasts for 12 to 24 hours. This is due to both the garlicky odor, pungent odor, and the direct irritant effects of the compounds. There is abdominal and intestinal discomfort, severe nausea, and there is black colored vomiting. Vomitus may contain blood and has a garlicky or fishy odor. Phase 2 is the quiescent phase where the patient and both the doctors who doesn't know the seriousness of the condition will think that the patient has improved and no further management is required. This is the most dangerous phase. Patient may not manifest any symptoms or signs, can have continued abdominal discomfort and appears seemingly. Phase 3, wherein the toxin has spread throughout the body, also called a systemic phase, sets in after 24 to 48 hours. The release of phosphine gas, which causes extensive cellular necrosis, as described earlier, and diarrhea with blood and mucus with severe dehydration can result. Patient may develop jaundice, spontaneous bleeding, and altered mental status, which is because of the hepatic encephalopathy. Lungs can show ARDS-like picture. It progresses to acute hepatic failure and complete renal shutdown. Hypotension, refractory shock, severe metabolic acidosis ensues, and patient can develop hypocalcemic tetany, agitation, coma, and finally death. There is no specific antidote. Management is often supportive. Things you need to remember here is normally use tap water for gastric lavage, but in case of aluminum phosphide or zinc phosphide poisoning, if you use water for gastric lavage and infuse water into the gastrointestinal system, more and more compound will get activated, and that will result in release of huge quantity of phosphine gas, which can cause symptoms very early. So gastric lavage with water or water containing liquid should be avoided. Potassium permanganate or a combination of coconut oil with sodium bicarbonate is the recommended solution for gastric lavage. But whenever infusing these compounds, we should take utmost care. Before going into gastric lavage, you need to secure the airway, or else it can result in aspiration and severe chemical pneumonitis. Calcium gluconate and magnesium sulfate IV to treat hypocalcemia and tetany. Treat the acidosis with IV fluids and vasopressors. N-acetylcysteine can be given within 12 hours of ingestion, which can reverse hepatic damage. But after 12 hours of ingestion, when usually patient presents to ED, N-acetylcysteine will become ineffective because the damage has already set in. There are certain case reports which showed N-acetylcysteine to save lives of patients if started before 12 hours, 2 hours of consumption of the compound. Dialysis, usually sled should be started to treat the metabolic acidosis. Soda bicarbonate IV is not going to work in this condition. And most important condition I want to stress on is, do not use for water for gastric lavage if you suspect poisoning with rodenticide, especially aluminum phosphide and zinc phosphide. So that is about your aluminum phosphide and zinc phosphide, for which there is no definitive treatment. If patient presents early, you can manage the patient with gastric lavage. Potassium permanganate and N-acetylcysteine can help. But if the patient presents after 12 hours where the damage is already set in, the damage is irreversible, and you need to counsel the patient about poor prognosis and non-availability of treatment. Next, let's proceed on to the anticoagulant compounds. Usually warfarin type anticoagulants are the first generation anticoagulant rodenticides. Most one-time injections of warfarin are insignificant accidental poisons that doesn't cause any manifestations. Significant coagulopathy requires large amounts in single exposure or repetitive exposure over several days. So usually the first generation warfarin type anticoagulants are harmless to human beings. Second generation super warfarins, once the rats have developed a resistance to warfarins, second generation super warfarins came into action, and indandione compounds were introduced as potent alternatives. They are responsible for 80% of anticoagulant rodenticide toxicity nowadays, especially in the Western countries. But they are quite costly, not usually used in India. The compounds usually used in India include aluminum phosphide and zinc phosphide. Mechanism of action of both the generation compounds is similar. Super warfarins exhibit the potent effect. Coming to the mechanism of action, you know that vitamin K, once in the body, is reduced in the presence of quinone reductase to vitamin K hydroquinone, which activates the vitamin K dependent carboxyl in the presence of vitamin K dependent carboxylase, activates the inactive factor 2, 7, 9 and 10 and protein C and S and converts them into active factors, and vitamin K itself is reduced to vitamin K epoxide. This vitamin K epoxide in the presence of vitamin K1, 2, 3 epoxide reductase is converted back to vitamin K. The anticoagulant rodenticides block one of these steps, vitamin K1, 2, 3 epoxide reductase, or the vitamin conversion of vitamin K to vitamin K hydroquinone in presence of quinone reductase. One of these steps is blocked, and so there will not be any activation of factors 2, 7, 9, 10, protein C and S, which leads to all the manifestations, bleeding manifestations. Clinical features of these super warfarins: they have a long half-life in the range of 45 to 120 days. Exposure to single dose can have no effects with warfarins. Repeated injections can cause severe bleeding. Symptoms include bruising, hematoma, gum and nasal bleeding. Warfarin assays can be done to estimate the levels. Super warfarins are not usually detected by warfarin assays. Management of super warfarins: gastric lavage if the patient has presented early with all precautions. Activated charcoal, single dose can be given. Obtain baseline INR and repeat INR at regular intervals, usually at 12 and 24 hours. If INR is greater than 2 and there is no active bleeding, oral vitamin K can be given. Dose of vitamin K is 1 to 5 milligrams in children and 20 milligrams in adults. Even if with vitamin K the patient is not improving and continues to have bleeding, transfuse fresh frozen plasma. In case of active hemorrhage, despite fresh frozen plasma, prothrombin complex concentrates and recombinant activated factor 8 can be considered. Prolonged oral vitamin K therapy is required as their half-life is more than 45 to 120 days. Let us briefly discuss about other compounds which are used as less commonly as rodenticides. Arsenic, toxicity manifestations are very severe. Mechanism of action includes it binds to the sulfhydryl groups and proteins. Clinical effects include dysphagia, muscle cramps, nausea and vomiting, bloody diarrhea, cardiovascular collapse, altered mental status, seizures, and late peripheral neuropathies, and repeated small dose exposures. Again, arsenic is one of the compounds which can be used for homicidal purposes. Arsenic is usually not detected and it mimics severe gastroenteritis and leads to severe dehydration in the initial phases. This is a cause for death usually. Treatment includes gastric lavage, activated charcoal single dose, catharsis, chelation therapy using either succimer or dimercaprol or penicillamine will be effective. Barium carbonate and other soluble compounds of barium chloride and hydroxides or sulfides of barium. Toxicity manifestations are severe. Mechanism is by depolarizing neuromuscular blockade. Onset is within 1 to 8 hours. Nausea, vomiting, diarrhea, abdominal pain, dysrhythmias, respiratory failure, muscular weakness, paresthesia, and paralysis. Gastric lavage with sodium or magnesium sulfate added to lavage solution to convert bicarbonate to less toxic sulfate, and potassium replacement is the treatment of choice. Elemental phosphorus or yellow phosphorus, again toxicity is severe. Mechanism by direct irritant effect like a caustic. It also uncouples the oxidative phosphorylation. There will be skin irritation, cutaneous burns, oral burns, abdominal pain, hematemesis, possible smoking, luminescent vomitus and stool, garlicky odor, direct toxic effects on the myocardium, kidney and the peripheral vessels. There can be cardiovascular collapse and late neurological depression with multisystem toxicity and hepatorenal syndrome can happen. Gastric lavage with dilute potassium permanganate solution may convert phosphorus to less toxic phosphates. Activated charcoal, usually avoid emesis, especially with water. N3-pyridimethyl N-paranitrolurea, PNU or VECA. Severity is severe. Mechanism of action includes destruction of the pancreatic beta cells with hours of ingestion by interfering with nicotinamide metabolism. Within 24 hours of ingestion, there will be GI symptoms. GI perforation can happen, autonomic nervous system dysfunction, insulin deficient hyperglycemia and diabetic ketoacidosis will ensue. Dysrhythmias and neuropathies are the late features. Nicotinamide IV is the treatment of choice, or lavage for recent injections, activated charcoal, supportive therapy, insulin for treatment of hyperglycemia and ketoacidosis is a supportive management. Sodium fluoroacetate, level of toxicity is severe. It acts by blocking the Krebs cycle, different stages of Krebs cycle, nausea, vomiting, apprehension, lactic acidosis, seizures, coma, respiratory depression, cardiac dysrhythmias, pulmonary edema, electrocardiographic abnormalities which are ST segment changes and T wave changes, tachycardia, premature ventricular contractions, ventricular tachycardia and ventricular fibrillation, hyperkalemia, hypocalcemia are very common. Treatment includes activated charcoal, seizure and dysrhythmia control and supportive care. Experimental regimens included glycerol monoacetate, calcium gluconate, sodium succinate, and ethanol loading. Consultation with a toxicologist is appropriate. Strychnine is a plant derivative. The toxicity manifestation is severe. competitive antagonism of the inhibitory neurotransmitter glycine at the postsynaptic brainstem and spinal cord motor neuron. We will discuss about strychnine completely in another video. Restlessness, muscle twitching, painful extensor spasms, opisthotonus, trismus, inability to swallow and facial grimacing, medullary paralysis and death can follow. Early airway control, quiet environment for the patient, just like how you treat a tetanus patient. Activate charcoal, and usually lave should be avoided. Benzodiazepines to control aggressiveness, barbiturates, analgesia, neuromuscular blockage may be necessary in the treatment. Tetramine, toxicity manifestation severe. It acts by blocking the gamma aminobutyric acid receptors in the CNS. It is a rapidly acting compound. As soon as patient consumes the compound, there will be headache, nausea, dizziness, fatigue, anorexia, numbness, listlessness. Loss of consciousness can be there, seizures, coma, and death will ensue. Median lethal dose of tetramine is 0.1 milligrams per kg. 6 to 12 milligrams sufficient to kill an adult. There is no antidote to only supportive care. Benzodiazepines or barbiturates may be used for seizures. Thallium sulfate, toxicity level of manifestation is severe. It combines with mitochondrial sulfhydryl groups, interfering with oxidative phosphorylation. Manifestations include early GI symptoms, and then patient will proceed into paresthesias, myalgias, muscle weakness, delirium, seizures, and coma, and finally death induced respiratory failure and dysrhythmias. Usually supportive care with multiple doses of activated charcoal or Prussian blue to interrupt the enterohepatic circulation and increase the elimination in stool. If not treatable, then you can go for hemodialysis. ANTU, alpha-naphthyl thiourea, severe toxicity. It increases the alveolar capillary permeability, causing pulmonary edema, dyspnea, cyanosis, cough, pleuritic chest pain, non-cardiogenic pulmonary edema, and pleural effusion are the manifestations. Supportive care and activated charcoal, there is no antidote. Cholecalciferol or vitamin D3 toxicity is moderate. Mobilization of calcium from the bones leads to hypercalcemia, osteomalacia, and systemic metastatic calcifications. Treat hypercalcemia with IV normal saline, furosemide, steroids, calcitonin, and bisphosphonates as needed. Bromethylene toxicity is low. It uncouples the oxidative phosphorylation. Muscle tremors, myoclonic jerks, contractions of the flexor muscles, ataxia, focal motor seizures can be noted. Decontamination, benzodiazepines for seizures are the treatment of choice. Red quill toxicity is low. Blacks, potassium adenosine triphosphate similar to digoxin poisoning. Nausea, protracted vomiting, diarrhea, abdominal pain. There can be hyperkalemia, atrioventricular black, ventricular irritability with dysrhythmias, which result in death. Treat just like digoxin toxicity. Atropine, external facing, digoxin specific antibody fragments, and activated charcoal can be tried. So coming back to our cases, the first case is an accidental poisoning. A 5-year-old male who has consumed cereals kept as rat bite and presented with bleeding diathesis. So what is the probable diagnosis in this case? Yes, you are right. It's because of superwarfarins. Remember, warfarin type of anticoagulants, which are first generation anticoagulants, will not lead to manifestations with single dose. Only superwarfarins can lead to bleeding manifestations with single dose. So management protocol we have outlined earlier. We need to follow them. Case 2. In this case, what are the clinching points here? Dark gray crystalline powder. And patient was initially had gastrointestinal manifestations. Then there is a period of quiescence, and then patient developed signs of liver failure. And despite all efforts, patient has succumbed. So what do you think the compound is? Dark gray crystalline powder is usually zinc phosphide, which is extensively available in India as sachets for rat bite. And there is a intentional poisoning. Young women usually have more chance of suicidal poisoning. So this is a case of zinc phosphide poisoning, the treatment which we have outlined earlier. Remember, you should not use water or water containing fluids for gastric lavage. This potassium permanganate or your coconut oil with sodium bicarbonate is the fluid for gastric lavage. There is no antidote. Patient is going to die irrespective of any treatment if patient has presented more than 12 hours after ingestion. If patient presents within 2 hours of ingestion, you can try with NAC. There are reports that the patients who consumed a toxic dose of zinc phosphide and aluminum phosphide have survived once they presented within 2 hours. Gastric lavage is avoided, or potassium permanganate used for gastric lavage along with NAC given. So you have to be very, very sensible in conveying the prognosis to the patients or the patient attender, because if you, when the patient presents to you, patient seemingly looks normal, if you tell the patient is never going to make it out, it might create a problem. So explain them what exactly will happen, then they might understand. Thank you. Don't forget to share and subscribe the videos. Thanks once again.